go ahead and get us started. So good evening. This is Smilow Shares with Primary Care, which is a monthly series with primary care here at Northeast Medical Group and Yale New Haven Health System, and our oncology Yale Cancer colleagues at Smilow. We like to discuss topics where they may present in primary care. Primary care may have some testing to do, evaluation, have to decide on referral criteria, and get a good sense of what's going to happen. We will today be focusing on hematologic issues with a special focus on when things are too high, and we'll get started there in just a second. But first, I want to make sure I introduce myself and pass it over to Ann Chang, who is in the Smilow Cancer Center, and will introduce her colleagues as well. So I'm Karen Brown. I'm the medical director of primary care at Northeast Medical Group at Yale New Haven Health System. And Frank Ciminiello is my colleague, also a primary care physician with a background of a chemistry degree at Georgetown University, working as an HIV case manager back in what we would call the day when there was uncontrolled HIV, and then went to medical school at NYU and did his residency at University of Pennsylvania. He did a clinician educator fellowship and was on faculty there for 4 years before moving to Connecticut and joining Pri-Med, which is a medical group, which is now part of larger Northeast Medical Group. He's received an MBA from the Yale School of Management and is now both the regional medical director for the Bridgeport region, as well as the president of the Pri-Med Physicians PSA. He's on the board of trustees and the CIN board of directors. And he lives in Easton with his wife, who's an OBGYN, so he always has extra perspective to add, and tells me that he's feeling miserably at learning tennis in a world of pickleball players. And I will pass it over to you to introduce the rest of our speakers.
Okay, thank you. Frank, that picture is a little old, I think.
That's all right.
Doesn't do you justice. Thank you, Karen. This is such a pleasure to be here tonight. I'm a medical oncologist and also Associate Yale Cancer Center Director for Clinical Initiatives. And tonight we have two Smilow colleagues of mine, Dr. Kelsey Martin, who's an assistant professor of medicine and hematology. She received her medical degree from the Royal College of Surgeons in Dublin, Ireland, and completed her residency in internal medicine at the Jacobi Medical Center, Albert Einstein College of Medicine in New York. She subsequently completed her subspecialty training in hematology and medical oncology at Lenox Hill Hospital in New York City, and has been here at Smilow since that time. It's such a joy to have you. And also, Dr. Martin's clinical interests include patient communication, hematology, hematologic disorders in women, cancer prevention, including the role of nutrition, obesity, and the environment in cancer. She's actively involved in the Yale community as a member of Status of Women in Medicine and the Women Faculty Forum. And she's a highly engaged member of the American Society of Hematology as a member of the Committee on Practice and representative for the AMA House of Delegates. Dr. Martin's interested in how sex and gender influence health and collaborates with the Women's Health Research at Yale. So thank you, Kelsey. And then I'd like to also introduce Dr. Anish Sharda, who's an assistant professor of medicine and hematology, and he cares for patients as part of the Smilow Classic Hematology program, previously known as Benign Hematology. Now we call it Classic. His clinical and research interests are in bleeding, clotting, and platelet disorders. His research in vascular biology is funded by the NIH. He received his medical degree from the B.P. Koala Institute of Health Sciences in Dharan, Nepal, and completed his residency at the University of Minnesota Medical Center, followed by clinical and research fellowship in the Hem-Onc Fellowship at BI Deaconess Medical Center and Harvard Medical School in Boston. So welcome to both of you. And
We
I'm
will
going to
turn
turn
it.
it over to Dr. Oh, sorry.
Oh, I was just
Right.
going to say, we're going to turn it over to Dr. Ciminiello to get us started with the cases. If you have questions as we go, please feel free to enter them in the Q&A section, and we will break at the appropriate point to answer them. It's part of what makes this series great is the ability to really answer questions real time throughout.
Yeah,
Right?
and I see some of our regulars, and you guys are always very engaged. So thank you again. I know it's a busy time. Happy New Year, and we'll get started. Thank you for attending.
Well, yeah. Thank you for attending. Thank you for having me. So these are two cases from my panel. The data is 100% like just transferred over, and then you'll see where maybe I could have done a little more before referral as well. So these are just real cases I thought would make the most sense to you all, the audience, and hopefully you agree. So we're going to talk about two cases where the blood counts are high, right? We think about referring for a lot of lows, a lot of penias, but there's a lot of elevated and abnormal blood counts when you start looking. And there's a substantial amount of pre-work that can be done prior to referral, which may actually eliminate the need for a referral in some cases, but also sort of identify people who need more urgent referrals as well. And so we'll go through these cases. If I get the next slide, please. So the first case was is a gentleman who about 8 years ago we saw for fatigue and not a significant medical problem history, just really high blood pressure was his only active problem. He was at the time on lisinopril and hydrochlorothiazide, married, no real significant social history, works as a social worker and licensed clinical social worker. BMI was technically overweight, but pretty good. And you can see his family history, which did sort of include some potential heme or hemonc diseases. So he came in for fatigue. We ran some blood work and found that initially his hemoglobin was elevated slightly. The rest of his CBC was generally unremarkable. We actually stopped his hydrochlorothiazide and rechecked, but the CBC was relatively unchanged. The hemoglobin had stayed in the 17 to 17.5 range, so mildly elevated. And other than the fatigue, really no other symptoms. We started the workup, which showed the normal iron studies that you saw before, and then sort of kind of and those were unrevealing. And then sort of the plan was sort of, what next? And so before we go back to him, just sort of a little bit of a reintroduction to people on the care signature pathways. And you can see that in the last few months, they've really increased, especially in some of the basic hematologic diseases, and you can see some here. As most of you know, the care signature pathways are pathways that are designed by a group of our local clinicians and experts to provide sort of best practices for a certain condition, a certain problem. We probably all know it started or really gained some fame with the COVID, but now is the number and then the depth of some of the information you get from there is incredible, and it's a live document, so to speak, where it's continuing to change, and so. So these are some of the new ones, or some of them, including some that are really relatively brand new. Another reason we picked some of these cases was to highlight some of the new care signature pathways. If I can get to the next slide, please. So as you can see here, there's a pretty substantial care signature pathway for an elevated hemoglobin. Should have mentioned in the history part that his pulse ox had been consistently normal. We saw, I'm on the right side actually now, some of the basic stuff. He wasn't on testosterone as well. But if you start looking, and you can see some of the things that we had done. Now, this was in my defense, it was 2015, so there wasn't a care signature pathway, but there was an up-to-date. So we did some of the workup. As you can see, there's probably a little bit more that we should have done. He certainly didn't need an urgent referral. But the care signature pathway really does sort of, I find to be incredibly helpful for a lot of the hematologic diseases in particular. I'm gonna, we'll go to the next slide, and I'm gonna pass this forward. But I'm gonna stick around if there's any questions for me.
Great. Thank you, Frank. So I'm going to go through initially some definitions of erythrocytosis, just because I actually think that's where the referral starts. Sometimes different labs might have different normal ranges, which could flag something as potentially being high when maybe we don't consider it as such. But there are sex differences in how we define erythrocytosis, and for 16.5 grams per deciliter for males and 16 grams per deciliter for females, with the corresponding hematocrit in parentheses following that. Our main goal for these cases is trying to distinguish primary erythrocytosis, which is really an autonomous production, and for the sake of this discussion, that really means polycythemia vera, which is a malignant disorder. Everything else, which is more common, would fall into secondary erythrocytosis. And these are situations in which it's not autonomous, or rather an external factor, which is leading to the boost of red blood cell production. And mainly this is driven by erythropoietin, or EPO. And this can happen for a variety of reasons. Both of these can be classified in another way, either congenital or acquired, but in our adult primary care practices, we're mostly going to be discussing acquired causes. I'll just briefly mention the idea of relative erythrocytosis, which I think is what Dr. Ciminiello was discussing in his case, where they discontinued the hydrochlorothiazide. Most of the time when we're thinking about a relative erythrocytosis, right, where there's a change in the plasma volume, creating this increase or apparent increase in the hemoglobin or hematocrit, we might often be talking about something transient, such as diuretics or GI losses through either vomiting or diarrhea. But I just did want to make a brief mention that there is a condition called case box polycythemia, which can really be thought of as almost a chronic form of relative polycythemia. And we might tend to see that in males with hypertension who are obese. So sometimes I personally find it's almost like a diagnosis of exclusion, but something that we do keep in mind. Go to the next slide. So, one brief slide here on polycythemia vera, because I think that's often as a malignant condition, something, of course, we don't want to miss. And this is a cancer, a myeloproliferative neoplasm that's really characterized by an increase in erythrocyte mass. Patients often have thrombotic, but sometimes bleeding complications, and can have vasomotor symptoms. For simplicity's sake for this discussion, essentially all patients with polycythemia vera will have a JAK2 mutation. So most of those are this JAK2 V617F mutation, and then a smaller percentage are kind of what we call other JAK mutations. And so if somebody has a JAK mutation negative, is extremely unlikely that they would have polycythemia vera. So this is a one proposed approach, but starting at the top left, again, that has just our definitions. This is taken from a European journal, so you can notice the change in decimal places. But following the definitions we outlined earlier for erythrocytosis, again, first excluding that relative erythrocytosis, which is really things like dehydration. Then we get to this next main fork in the road, and of the next kind of very useful test that can be done is the erythropoietin level. And whether that turns out to be high, low, or normal, that helps bring us into the next most likely leading us down the diagnostic pathway. And so if the erythropoietin level is high, we're really looking at these secondary acquired causes. So not polycythemia vera, not a cancerous condition, but something else driving EPO levels to be high. And often the main reasons here are hypoxia and medical conditions that cause such, and medications. We're rarely going to see congenital associated causes in practice. If the erythropoietin level is low or very low, then that's where we often will next check the JAK2 mutation testing. Again, if it's positive, that confirms that someone has polycythemia vera. If it's negative, we'll look for those other JAK mutations. Again, if these are all negative, it makes it very unlikely the patient has polycythemia vera. Go to the next slide. Okay, so again, in terms of our diagnostic approach, the first most important lab to check would be an erythropoietin level. And again, if it's low, that really points us in the direction of polycythemia vera. And if it's normal or elevated, then we're going down the more common likelihood of secondary etiologies. So this is just a list of diseases that as primary care providers, you might commonly see in your practice. That can again have a erythrocytosis and with either a normal or increased erythropoietin level. So cardiopulmonary disease and obstructive sleep apnea, I think are quite common in our patient population, given that we don't live in a high altitude. Cigarette smoking, often I think we might see either separate but often together with cardiopulmonary diseases. And then I just wanted to bring attention to carbon monoxide poisoning as, of course, something we wouldn't want to miss, and that can be identified on lab work. And then also a list of medications here, pointing out that SGLT2 inhibitors, the drugs that end in the flozins, we're seeing an increased number of these prescribed as in our patient population, and we do see erythrocytosis from these. So just keep that in mind, kind of doing a quick medication check when you notice higher hemoglobin in your with your patients. In addition to things like testosterone, I'd say that's also often prevalent in our patient population. I personally don't see that many patients using EPO doping, but of course it I think intuitively makes sense to think about that. If we talked about the relative erythrocytosis, and then if we see a high EPO level, tumors, both malignant and benign, including like uterine fibroids, which is something I've seen in practice, can actually secrete EPO. And then also renal conditions, so renal artery stenosis, renal cysts, and patients who have also had a kidney transplant as well. So in terms of other labs to check, in addition to those iron studies, a lot of our patients with polycythemia vera will have kind of low iron at baseline, which was checked in your case. And also a blood smear is useful really to look for some of those kind of more ominous markers, sort of blasts, which could be seen. It could highlight a potential malignant condition, or what we call leukoerythroplastosis, just sort of these younger precursor cells, so nucleated red blood cells, for example. Again, just this was, I guess, kind of outlined on the prior slide, but just in a different format. I think some of these are relatively common conditions in the primary care population. Just as you, after you've checked an erythropoietin and you see that it's either normal or high, you can kind of try to go through this list of different possibilities. And again, we just wanted to highlight particularly this last bullet point here, as we're seeing more of these prescribed in practice. When we're taking a history, I think it largely is going to, the medication list, obviously, we might have in front of us. We're going to take a smoking history, of course. Do you have a carbon monoxide monitor in your home? And symptoms of, I think, sleep apnea are quite useful. And on our physical exam, hypertension, plethora, signs of scratching or itching from pruritus patients might experience. Certainly if someone has splenomegaly, I think we're really going to want to make sure we're ruling out any malignant etiology. So these are helpful things to look for. So who should be referred to hematology? So I would say my recommendations would be anybody who has a low erythropoietin level, someone who has really long-standing erythrocytosis or a clear family history, or patients younger, because while they're quite rare, there are we do have a handful of patients with hereditary forms of erythrocytosis. Certainly somebody who has a JAK2 mutation. And then I think that there are patients who we might feel have symptoms related to erythrocytosis, which can be challenging to manage. So headaches, for example, I'd say would be a very common symptom, kind of mental fogginess, would probably be a second thing I would think about. And so certainly if there's concerns that symptoms patients have are related to erythrocytosis, I think we should see those patients, in my opinion. I have one brief thing on how we manage polycythemia vera, only because it often, in the past, how we manage polycythemia vera sort of trickled into how sometimes we might think we should manage other causes of erythrocytosis. But very briefly, these patients have phlebotomy to reduce their hematocrit, often to a level less than 45. Most of these patients are on aspirin, and sometimes they receive cytoreductive pills like hydroxyurea or others. But for secondary erythrocytosis, we really should not be doing phlebotomy. It's really the take-home point of this. And the treatment is really directed at the underlying cause if we think it's even necessary. Especially when it comes to hypoxic pulmonary disease, right? We might see this in more advanced forms of COPD or OSA, and the prognostic significance is not exactly clear. There's sort of mixed data in this space. And there's really no clear evidence that phlebotomy is necessary or even effective at reducing thrombotic risk, and could actually increase thrombotic risk. And certainly to try to assess someone's thrombotic risk, we need to think about other risk factors patients might have. We do know that when patients with OSA are on CPAP, it can reduce their erythrocytosis, but otherwise, in terms of directed management to lower the erythrocyte count, its data is less clear. One brief slide on testosterone, because we see a lot of these patients as referrals. We know testosterone can cause erythrocytosis for a few reasons, but probably initially due to a rise in erythropoietin levels. Often patients have been referred to sort of decide if they would benefit from phlebotomy, and there's not really a clear data to say we should do that, and it may actually make things worse. So going back to our case, I think that the JAK2 mutation was negative from what I recall, so we're now kind of going down this path of what we call secondary causes. For this patient, I would say it's really crucial to rule out medication-related causes, certainly check for carbon monoxide poisoning, and I think checking the erythropoietin level will help kind of guide us on next steps. Commonly, we might have a patient who has signs or symptoms suggestive of sleep apnea, and a referral to pulmonary or sleep medicine sometimes can be useful. And I do not think there's any role for therapeutic phlebotomy in this type of case.
Great, thanks. Before we do case 2, since this was 8 years ago, I can give you the final. So he did have an epogen level before seeing hematology. It was negative. And then he saw Dr. Persico, who did do the carboxyhemoglobin study that was normal. And he did the CALR exon analysis as well, which was negative. The workup eventually found that he had some mild to moderate sleep apnea, and he's been on CPAP since, and his hemoglobin has been generally staying in the 16 range, so upper normal, and remained off because he didn't, we switched his blood pressure around blood pressure medicines around off the hydrochlorothiazide. So, and he may still have a little bit of fatigue, but who doesn't? Thank you. The second case is this one is actually sort of in the workup now. It's a 74-year-old woman we saw recently just for routine follow-up. She has some chronic medical problems, including obesity, AFib, hypertension, hyperlipidemia, a remote history of adrenal insufficiency. You can see her medications. Most of them are old. The Gemtesa is, the maybe more new. She was a former smoker, a fair amount, as you can see, 10 to 15 pack year. And her family history also, interestingly enough, has possible hematologic positive finding with the what she says is her father had elevated blood counts, but didn't necessarily, or she didn't know the diagnosis per se. So so this is her. We did some blood work, and you can see her white count upper normal, hemoglobin normal, and platelets were elevated, repeated, and were pretty similar in the 450 to 525 range. No evidence of kidney disease, liver disease. Did do an ultrasound as part of the workup as well, which showed evidence of fatty liver, not surprising given her medical history, and no evidence of any splenomegaly or any abnormalities in the spleen. So this one's ongoing. So we're next to order the blood smear, but thought, unlike the other case, we can do sort of a fresh case. And you can see, again, a care signature pathway showing no real alarm symptoms, which is good, but a peripheral blood smear that's sort of, ordered, not done. So you can see on the bottom, some more worrisome findings that we haven't gotten to, hopefully won't get to, but haven't ruled out yet. So I'll pass this on to our expert, and obviously I'm around for questions.
Thank you. So I think unlike erythrocytosis or polycythemia, the workup of thrombocytosis or some, I misspelled it here, the expert, but it's I think clinically and both the laboratory evaluation and different causes, it's just a lot more simple or simpler, and perhaps reflects the physiology, because the platelet production and its regulation is so much simpler than red cells. There's no kidney involved, there's no liver involved, and there isn't a feedback mechanism that's related to kind of oxygen levels or hypoxia or hyperoxia. And so thrombocytosis is especially isolated thrombocytosis, and this is what our patient here has, is mostly incidental. And with that, what I mean is, most of the time patients are not very symptomatic, and these are picked up either routine labs. They could be peri-op, they could be just their annual physicals, or otherwise. And to sum it up, most of the times when we're dealing with thrombocytosis, or especially a persistent thrombocytosis or elevated platelet counts, we want to perhaps figure out whether it's reactive or essential. Next slide, please. So when I'm seeing a referral, of course, I go through history and that, and just trying to see whether there are any symptoms, which most of these patients typically don't. I feel patients with polycythemia or other myeloproliferative neoplasms typically tend to have some more symptoms, especially on, when we get down to more direct questions. Thrombocytosis can also produce some vasomotor symptoms, and I've certainly had people with migraines or with other vasomotor symptoms that get better with treatment, especially with essential thrombocytosis. But in history, other than that, I'm just trying to figure out, whether the person is asplenic, and it happens less so, but certainly, we see people from time to time getting either traumatic or other for other reasons getting splenectomy or and are asplenic on that, and that will always cause kind of mild to moderate thrombocytosis. And then the trend is really important because um, uh, if it's really you look back and someone lives around 100, 150 or 200 and slowly the numbers have been creeping up and they just recently have come up to maybe 450 or 500 range. It kind of gives a sort of sense that maybe this is an essential thrombocytosis, and usually takes years to kind of double, or the doubling time is typically very, very slow. So trend is important. And then if I see someone who perhaps goes up to 600, 700, and then goes back to normal, and then goes back again, I typically, like after finishing the workup, realize that these are mostly kind of reactive thrombocytosis. And and then, with recent history of, surgery, sometimes like patients can have very extensive surgery, especially orthopedic surgeries, very well described. Hip surgery, for example, hip fracture surgery, patients can have first thrombocytopenia and then, reactive thrombocytosis that can last for months. And the same is with chronic infections. It could be osteomyelitis or, other chronic infections. Even acute infection, viral infection, you would see not only, ITP or, thrombocytopenia kind of syndrome, but a thrombocytosis that could last for weeks to months, and then other chronic inflammatory states, especially rheumatologic diseases, but even milder general sort of, or inflammatory kind of conditions, even diabetes or a poorly controlled diabetes or others. And then some medications as well. I mean, I've certainly seen patients getting steroids. The last one I saw was, a person getting, I think epidurals, and every time, it'd go up and then come down, and then 6 months later, it'll go up and come down. So definitely, steroids can do that. Stimulants also I've seen, especially with methylphenidate. It's not been reported, but, I think I've seen a bunch of patients who really go on it. The platelets go high, and then, and then they're off of it, and it comes down. So, and then there are other, chemotherapeutic agents, and gemcitabine is a big one where, you could have really extreme thrombocytosis, but those would be rare. And then coming to the laboratory workup, and so, they've had at least a few CBC, but, that's what we end up getting. And smear becomes very important because many times, thrombocytosis also causes, how do I put this? Some degree of pseudothrombocytopenia. And what I mean by that is, like, you'd see a platelet count of 500 or 600, reported platelet count of 500, 600, and then you look under the smear and there are many, many, many clumps. And so, especially with essential thrombocytosis. And so the, the platelet count, the actual platelet count is way much higher. And I sort of, like, see that a lot more with inflammatory states. But anyway, smear is pretty useful, especially you're also looking for other atypical, cells, or, sometimes they're not reported or they're within the normal range, and you appreciate, maybe or question dyspoiesis or so smear becomes very important. And then ferritin, and with that, what I mean is iron studies. I personally just, get ferritin, and that's my iron panel. But in in outpatients, the most common cause of thrombocytosis is iron deficiency, and now the biology and the mechanism behind it is also very well known. In fact, you can kind of divide the humanity into two: those who would really have thrombocytosis and those who wouldn't with iron deficiency. And so this is perhaps the most common cause, iron deficiency being for thrombocytosis. And then once you've really ruled out all of this, which is no inflammation, infection, surgery, even 3 months ago, they're up to date with cancer screening and everything, and then the likelihood of a persistent thrombocytosis being essential thrombocytosis or thrombocythemia is more. And then that's really diagnosed by mutation testing. So 50% of those will have JAK2 V617F mutation, and then about 30% will have CALR. And then 5 to 10% will have the MIPL or MPL mutation. So that makes it 80-85%, and the remaining would require a bone marrow biopsy for diagnosis. And these days we're with sending a bigger myeloid panels. We are finding other rare mutations that are associated with essential thrombocytosis, and so that's really the laboratory workup. Next slide, please. And so just summarizing, what I just said, most common etiology is iron deficiency. And so your iron panel is it probably will rule out, good, 20-30% of the cases. And then followed by reactive or secondary cases, such as, post-op status or, in chronic inflammatory conditions. Many times we finish the whole workup, including bone marrow biopsy in a younger person, and not really get a diagnosis, and that's perhaps because of I have kind of seen people developing diabetes or very general kind of mild chronic inflammatory sort of states, and then once these have been ruled out, then a workup for myeloproliferative neoplasm is justified, and that can just be started off with a JAK2 mutation and then reflects to other mutations followed by bone marrow biopsy.
All right, no, thank you. So this, like I said, this case is sort of ongoing. I'm suspecting we won't find a cause, but we have the smear still coming on. And then just one final plug on the pathway. So, when you're putting, at least for me, when I'm putting in the smear order, if you type in peripheral smear, it doesn't always show on the order what you want. But if you click on it from the pathway, it pops up. And so for those of you taking notes at home, it's peripheral smear for pathology. If you type in peripheral blood or peripheral blood smear, you actually doesn't always show up in Epic. So another plug on the pathway for in some ways it may be sometimes worth the time to go in just to make the ordering easier. And so, like I said, her case is ongoing. I'm suspecting, since she's been relatively stable in the 450 to 525 range, that we will probably not find anything pathologic. But I'm happy to, when I'm back, if people want, give another update. I haven't been following the chat. I don't know if there's any questions. Otherwise, I'm going to pass it back over.
Yeah, no, we have not gotten any questions, although we had a couple of other things that we didn't know if we were going to have time to discuss. And so maybe we can pull those in. And if you do have questions, please enter them in the Q&A.
Well, I have one.
Can I ask something too?
Oh.
Yeah, go ahead.
Yeah, no, mine is a question, so it's a complete change. So you can.
Okay, I was actually going to ask because I probably missed it in your case, and maybe to Dr. Sharda as well. about if your patient's body mass index and if they're obese. You might have said that and I missed
Yeah,
it,
no,
but I
yes,
think, yeah,
good
I think I see
question.
that a lot in practice as part of this inflammatory state.
Yeah, yeah, and no, I completely. Her BMI is 37, and that's why I think we're not going to find a pathologic
Okay.
cause. This wasn't a question, but it makes me think of something like we didn't talk about leukocytosis, but I sort of feel, and I haven't looked this up, so if this is obvious to everyone else, I apologize that a fair amount of people with higher levels of obesity seem to have like a white counts of 10 to 12, nothing that's sort of triggering a workup, but seems to have. And so I wonder, like you said, if there's another sort of, like Anish said, like maybe there's a little bit of non-pathologic chronic inflammation that's driving some of these thrombocytosis that may be causing a little bit of leukocytosis, because I do see that a lot. So good question about the BMI. Yeah, hers is 37.
Yeah, and yes, I think we see a lot of patients with leukocytosis who are with an elevated BMI, and there's increasing, I think, literature on that that I've looked at that I think's really fascinating. So yeah.
We have a comment from Marianne Davies. Thank you for a fabulous presentation and thrilled that you highlight the care signature pathways and the value for primary care. Marianne, thanks for the work that you and your team do on the signature care pathway. And thank you for sharing the slides that some of the slides that we used. So thank you.
Yeah. No, and they're well done. I agree with Frank.
Yeah, and the fact that they're living and get updated. So right, we highlighted these topics because there was a couple of new ones, but they'll change as need be, which is great. Like, I don't know if there's no other questions at a time. I did have one question. We see a lot of elevated through both of these cases, right? The workup was, let's get some iron studies. And I will say, in primary care, I do see a lot of iron studies that show an elevated ferritin. And often my mind goes to, is this hemochromatosis, and do I need to worry about hemochromatosis? And so I had a question of what would be maybe the best marker or trigger that you would want to share with your primary care colleagues of when is it worth the testing for hemochromatosis?
I think an iron saturation of more than 45% is usually a better test to kind of screen for hemochromatosis. So I think, but certainly other ways that someone might come to us too. I mean, sometimes patients have had, an MRI, and if there's sort of iron deposition on like a liver MRI, I think that's certainly, we think about that as well. But the ferritin, in a similar vein, has a lot of sort of reactive, as an acute phase reactant, we might see a high ferritin, or from liver diseases and other spaces, alcohol. I don't know, Dr. Sharda, your thoughts?
No, I agree, and then it becomes tough because many times we end up seeing people who've already had mutation testing, and then they have either the H63D or just they're heterozygous, and then you're just stuck with someone with a ferritin of 700-800, who perhaps has if you follow if you're purist and follow the textbook, you shouldn't be phlebotomizing, but you end up you're just stuck there in the middle. But yeah, ferritin becomes really tough too, and it's got very much longer half-life. I feel, I guess, not half-life in terms of the protein, but like just physiologically, because after acute infections, I think, in surgeries, ferritin can be high for a very long time. And so then it becomes hard to, obese people, individuals, diabetes, having surgery, or, foot infection, it just becomes very difficult at some point.
Yeah, that was another good pearl. That and the SGLT2 inhibitors. Those are some good pearls to live by. Yeah, I'm curious. Now I know that this could be an entire presentation in and of itself. But we talked about high platelets, and now that patients can see their own results in my chart, we get a lot of very pointed questions. The ferritin would be an example, platelets, and are you sure there's nothing wrong? And I want to see a specialist. I mean, it's a kind of interesting situation where things that we never had to completely explain, we now have to explain. And there's always a kind of fear of like, are we dismissing something when it gets called up that way? And the other thing that comes up a lot is, these kind of intermittent, very mildly low platelet counts, where, if you can actually do a smear and see clumping, you're like, amen, hallelujah, nothing to do. But otherwise, again, I don't think people bleed until they go significantly lower. But what should be our threshold for doing a workup? And what should we tell patients when it's just really not a problem? They're only very mildly lower. Anish, I think it's your turn.
Okay.
Yeah, you're up.
No, I agree. And I think I don't think there's even a term called minimal thrombocytopenia, but I tend to use it even in my description and note. Because if you're a purist like I am, definition of thrombocytopenia is less than 100 actually, because people have gotten together and actually the world thrombocytopenia, whatever, so is less than 100. But if you see the CBC and what any lab, they would still report normal as 140, 150, 160, whatever their lower range is. And so and it's a lot, it's more common than thrombocytosis, or I would say, at least in my experience. And I agree. I mean, it becomes, I think they just need reassurance. We see plenty of it. I see plenty of it for referrals. But they just, they just need reassurance, because I agree with you that usually there's no bleeding even at 50, or 50 is you can get a hip replacement. I mean, it's usually, the risk of major bleeding is 5% with less than 20. So you don't, there's a lot of redundancy, and so usually 100, if they're really greater than 100, and you have repeated it, and it's still greater than 100, or it bounces around, it really, I think, is very reassuring. And that, one could just be clear that actually the real, we call low platelets, on the medicine, from the real definition is less than 100. So
That is
I don't know.
another great pearl. We have like just pearls flowing. These are really wonderful because, I don't know about you, Frank. I see, CBCs. I probably look at, I don't know, 20, 30 a day. It's a lot, and they all have things just outside of normal. And so this is very helpful, to not kind of over refer things that are, pretty clearly fine.
Yeah, I think
Oh,
that
yeah.
I agree with everything Dr. Sharda just said. And I think that like the sometimes like just in terms of what to say to patients, and just some patients I think accept that idea of like you could have a surgery at this level, and then that's, I think, just like clinically people can, that somehow resonates with people. I think, if there's, assuming it's just isolated thrombocytopenia and not, there's no other kind of cell lines, I think the age of the patient, right? Like, and then I guess just as I'm sure we do, even if it was mildly low, I guess I would just add that if it was recently much higher, then like maybe I personally would monitor it. And then I don't know, I look at the mean platelet volume, which, might be one of the things that just otherwise gets disregarded. But if it's a little bit high, I mean, sometimes I think that's kind of these autoimmune-ish people, not that anything needs to be done, but I think that that's something we see a lot in practice. But I think it's Yeah, I think just sort of how we reassure patients in general is hard. I think that it's a difficult, there's a lot of things on a CBC that we don't really probably look at in such great detail, but to patients, that MCHC is crucial to their, you know, well-being. And that's hard, I think, too. It's
And
just
if
like
I,
the number of data points, you know.
I think if I may, like, I think, um, mm, just wanted to bring it up, but that, like, for someone we're dealing with who's really not being reassured and would really like, like even one sentence from, from a specialist. I think for cases like that where, it's very borderline thrombocytosis or a very borderline, thrombocytopenia, I think e-consult is a very nice pathway too. And I'm not sure, if it's, to what extent kind of, it goes out into this, world, like in the whole system, outer system. But I certainly do it, a few weeks a year, and those are, they take 2-3 minutes. I mean, and someone signs their life that, this is fine, and so I think that could, be reassuring to everyone and save everyone's time, including patients, and because it could take a long time to get a referral for something like that.
That is another very helpful suggestion. So we have a question from an anonymous attendee, and it says, "What pathways are available? I only saw iron deficiency." So all of the ones that we showed are in there. Actually,
Can we go
may I
back to
add?
that
Yeah. Oh,
that
yeah. There was a
slide?
table of contents of that. It was like slide 17 or something.
Renee,
Renee.
are you able to
Oh,
show
she might
that?
have stepped away.
I'll try to share it, but let's see.
Yeah. Okay.
Oh,
Oh,
there she
here it
is.
comes. Good. Yeah,
Always
there we
on.
go. Yeah. And if you can make that bigger. So we have thrombocytosis, lymphocytosis, ferritin evaluation, and erythrocytosis are what I'm reading with my face right up to the computer. And bleeding, concern for bleeding disorder. And these were launched, they're a little simpler than some of the other pathways. And so they were kind of launched. There's actually some more ready to go in hematology, if people find these helpful, which I think we've had a resounding endorsement. Frank, you looked at that. You're like, these are great. So, and of course, there's a ton of pathways and other things, diabetes, hypertension, not other things aside from heme as well. And whoever it is that asked can always send me a quick note, and I will make sure you have somebody help you find the additional pathways.
And if you
Frank, I'm going
can't
to go
find
back.
it, and if you can't find it, maybe that's a reason to, put it on the list. Maybe it's being added as we speak, but maybe it's on the list. If not, we could put it on the list.
Exactly.
Well, it
Frank,
looks
I'm going to
like
go
we
back.
are nearing the end of our hour, where Kelsey's daughter has announced it's time to come have dinner or something, right?
I was going to go back to Frank, your background slide introducing this whole thing, which was sort of elevated blood counts, and that, it's so common every day. You're looking at so many CBCs, trying to figure out what to do beforehand versus who really needs urgent care, or urgent referral, or, accessing e-referral. Do you and Karen feel like you have a good handle on that? Are there other instances where you're thinking that you need a little extra help, or that you're not quite sure where to go from there?
I think, like what Karen said, sometimes managing like sort of the patient expectation is sort of our other job, right? Besides just handling the medical stuff. And so sometimes there is no amount of reassurance I can give someone. And so there is unfortunately it is what it is, patient-driven referrals. I mean, I think I would say the other ones that come up, so the gammopathy or the MGUS pathway, I think I use a fair amount, or can see myself using a fair amount, which is great. And then I think someone alluded to you see a pre-op. Someone had asked for the PT and PTT, and it's mildly elevated, and then you're like, well, now what do we do, right? And so that's another, I think, really, like, if you bookmark things, like, is this a bookmarkable one? So those, I think, are good. I've not used the e-consult as much, but I feel like there's just a hidden, or not so hidden, like, potential to really improve the throughput between primary care and heme with that. And so I feel like that's something that we should take back and figure out, how do we make this more used more.
Yeah, it's pretty user friendly. And it's nice because so many of us kind of do curbsides, right? We phone a friend, but that's not in the chart. And it doesn't have any credit. There's actually billing credit for the specialist through the e-consult. So they kind of get productivity credit, and we get a very clear answer. And again, if we want to, we can have a whole nother encounter to discuss the answer if it's complicated, or we can just simply send the patient a note, or call the patient if it's kind of what we were expecting to say anyway. So, all right. Well, I have to thank our speakers very much for all of the preparation and wisdom and pearls that came through, and Frank for keeping us on